Hi everyone and welcome to the NG Podcast. I'm Marcus Einson, your host. In the NG Podcast we hope to bring you content that's of interest to anyone involved in enteral feeding, whether you're a healthcare professional, a patient or a carer. We hope you enjoy this episode. Please subscribe or like on whichever platform you're either viewing or listening to this on. Here we go. Today I'm joined on the NG Podcast by Phill Johnston and Joshua Beattie. Joshua, do I call you Josh?
Josh is fine, yeah.
Okay, it's kind of...
I haven't been naughty yet, so that's fine.
Some people like their full name. And they're both dietitians at the University Hospital of the North Midlands. Welcome, guys, and thank you for taking the time to come on the NG Podcast. I know that we're here to discuss your experience with NGTs, but this morning I saw some discussions on Twitter about the low numbers of male dietitians. And as coincidentally, I have two of you on this call today. I wondered if you have any thoughts on why that's the case and what could be done to attract more men to the profession.
We had a bit of a chat about this in the office beforehand, actually. Thought it was quite an interesting question to touch on. I think when you look at healthcare in general, maybe aside from sort of doctors and physiotherapists, it does tend to be more female orientated. I think that's quite a historic thing, and you see typically women have been seen as the more caring of the sexes. It does seem to be changing a bit more recently, but yeah, there's certainly lower numbers in terms of our profession.
Yeah. I mean, through my childhood, my sister was anorexic, so I was quite aware of dietitians and what they do. But it was only when I got to the college level that I thought, I'd give that a go as a career. I think it's generally maybe it's not a well-known profession. We were saying again before, if you get poorly as a kid, you go to a doctor. If you break something, you probably end up seeing a physio. If you need a jab, you see a nurse. But because everybody eats and everyone has their own opinions on food, we don't necessarily think dietitian. Maybe more people think nutrition before they think dietitian.
Yeah. Okay. Interesting. Some people who follow Twitter may have seen that during Hydration and Nutrition Week in March this year, Josh took part in the challenge to live with an NG tube for a few days to gain insights into the patient experience. Interestingly, though, Josh, that wasn't how it turned out, was it?
No, unfortunately not. I thought originally it'd be a really good thing to do is in my specialty area, I work with oncology patients, so mainly head and neck cancer patients, but also sort of general oncology, hematology as well. And a lot of that role requires sort of enteral feeding, whether it be sort of NG tubes or NJs, whether it's pegs and rigs. It varies patient to patient, but we on a daily basis make these recommendations that patients have the feeding tubes, but then quite rightly they ask, well, have you had one? Have you been through it? And how many of us can actually say, yes, I have, and this is what it's going to be like, and this is what to expect, sort of thing. So I think in terms of giving advice and recommendations to patients, I think it's actually really important that we get more of an insight into their experiences. So yeah, that's basically why I wanted to do it.
Okay. And UHNM have the dietetics team are pretty lively on social media in general, and you do tend to do stuff for Nutrition and Hydration Week. But even for your team, that's a little bit out there.
Yeah, I just thought it was something a bit different, and it gets people talking. And I think that's like coming back to the previous question about sort of exposure for our profession, I guess, then that sort of thing is actually really important. And getting ourselves out there, making a bit more of a buzz on social media, people just seeing what we do on a daily basis, I think is really helpful to improving our reputation as a profession.
Fantastic.
Because we work with NG tubes every day, we thought it would be mostly positive, and we had a few negative comments which surprised us really, because there were people suggesting, why don't you just read the research that's already out there, or is this good practice, which as professionals completely baffled us, because we thought, why don't we want to get into the mindset of our patients and understand what they go through so we can sympathise with them? and talk through what is going to happen.
No, actually, I think I've spotted a little bit of a trend because I know Sean White from Sheffield lived with an NG tube for a week a few years ago, but all of a sudden I'm seeing lots of pictures of dietitians and with NG tubes down, and I have to say I'll probably get flack for this, but I haven't seen many nutrition nurses doing it. So maybe we can start a bit of a competition on that. But yeah, I agree. I think it's always good to get that experience. Although in my background, I was a urology nurse and I've never felt the need to have a catheter.
No, it's a different type of tube. Yeah.
Well, unfortunately, I've had that as well. So I know which tube I prefer.
Okay. So Josh, when you did actually start the challenge, and so how was it having the tube inserted?
You know what, I was actually gutted that I couldn't carry on with it, because I was really looking forward to getting stuck in and doing it properly. Unfortunately, it didn't quite pan out that way, and it wasn't how I was imagining it going. So the tube insertions themselves, I'll be honest, I didn't find too bad. I had 3 of them passed in the end. The first tube went in okay, but we couldn't get a pH, so we couldn't use it. And obviously, it doesn't make financial sense me going for X-rays and things when this is and there's a bit of an experiment. So the second tube, then it was a lot more challenging getting it in place. And when it did go in, I couldn't stop gagging. So the nurse on the ward who had kindly passed it was really good with the NGs. She used to do them all the time, but I just couldn't tolerate that tube. And even without talking, I was gagging and retching all over the place. We took that one out, and then a bit later on in the day, I went to one of the NT consultants who I work with, sort of as part of the head and neck team, and he passed one on me, and it went in okay again. I managed to get home with that tube, and I managed to give myself a feed. It was more just that every time I tried to talk, I was just gagging, and I was thinking, I've got to come into work tomorrow. I've got to do a job. It doesn't really look very good if you're talking to patients about what they're eating and then you start making sick noises in their face. So yeah, the tube insertion experience wasn't as bad as I was expecting it to be. It was just the aftermath really that was caught me out.
You look really poorly with it as well. He was green, and there's a video of him taking his NG out, and he just looked so unwell. It's not.
I actually didn't realise that you'd actually managed to get home with one. I thought you hadn't even left the hospital.
No, I did get there. Yeah.
So the first 2 you said about not being able to get aspirate. Did that surprise you? With you being a healthy, fit person who could, I guess, move about if that's what was needed? Did it surprise you how difficult it was to get aspirate?
It did a bit, yeah. I don't take any. I don't take a meprazole, lansoprazole, anything along those lines. I hadn't eaten yet that morning because the plan was I'd come into work. I was nil by mouth and coming into work for the NG insertion, so maybe that had a bit to do with it. When the third tube went in, I got a pH no problem, and it was less than 2. Thankfully, it did work, but that was part of the experience. Really, is that these issues do happen, and you sort of feel for patients when they're sat on the ward waiting to start feeding. And they're sort of really hungry just because they haven't been able to get an aspirate from a tube or not been able to get started. So all part of the experience.
Yeah, and an interesting one, because I have to say, when we did our healthy human volunteer trials, we 37 tubes down people in that, and they were all healthcare professionals from the hospital, and we had no problem getting aspirate. But that was probably the middle of the day, so they would have eaten and drank. So maybe that's the difference if you'd actually starved before. But I think the point about being able to think about a patient who sat there waiting, who actually needs nutrition, and the delay is a really good insight. You know, even if that was the only insight, it's a good insight.
Yeah. Which
I know that isn't the only insight from this. So. So, Phil, you'd obviously had seen Josh looking a bit green, and you still volunteered. That makes me think you were even braver having seen it.
I'm not too sure about that. When I found out Josh was doing the NG, I was jealous more than anything else. I really wanted to give it a go. It's always something I wanted to do, and it's something I wanted to experience. Just to, like we were saying before, to put myself in that patient mindset. So it was once Josh came in the next day and his tube was missing, I jumped on the chance really. I said,
Yeah.
"Oh, do you want me to carry it on for you?" Because I just thought after all the work the department had done, let's say with the Nutrition Hydration Week, and because a lot of the stuff earlier in the week is probably the same as what departments do every year and up and down the country, to lose probably the most unique aspect of the week, I would have thought would just been a massive loss.
So, compared to Josh's insertion, what was yours like?
My the insertion itself I thought was absolutely fine. I went to one of the wards I work on because I'm sure, like many dietitians do, I know which nurses I want to go to for issues regarding feeding tubes because I know they'll sort it, or I know they'll get an NG in straight away. So I went up and found the nurse I was after, and I said, "Oh, can you put an NG in on me?" And she thought I was joking, and I said, "Oh no, serious. I want to be NG fed." Um, so we got all the stuff, and we went into our clinical room, and within a couple of minutes, it was in. The only uncomfortable part was that the eye on the same side as the NG started to stream, and then the lubricant they used to get the NG up the nose and down the throat, you could just taste that in the back of your throat. Other than that, I thought the experience was fine.
After that initial insertion, which obviously went pretty well, did everything settle down immediately? Was it plain sailing from there?
No, not by any means. For that first evening or the rest of that day with that tube, I was miserable, and it was just such an unpleasant experience at the time. Every time, if I spoke in long sentences, I'd start to gag. If I turned my head to speak to someone, I'd start to gag, and it was just generally uncomfortable in the back of my throat. And I think with Josh as well, but we both only had 8 French NGs in. So when you see patients who've got huge tubes in 10, 12s, 14s, my level of empathy shot up through the roof. It was just so unpleasant for that first period.
Yeah, I mean, interestingly, before we started, I said about I'd been talking to some people in France before I came on to you, and I asked them about what size of tubes they use, and they said we usually use a 14. So I said to them that they're quite cruel to their patients in France if that's the case, because a 14 is a big beast.
Yeah. And that's one of the debates I find, especially patients who have been on critical care. So they've either needed medications crushed or, well, that's the main reason really, but who have come down to the step down wards with these big tubes and aren't progressing as well as what I'd like from a nutritional perspective. I'm always asking, can we change the NG just to get something a bit more comfortable and hopefully free up some space in the esophagus?
Yeah, and now you really know how much more comfortable they'll be.
Yeah.
So I mean, is it from that sort of experience that when I read your article in the BDA, you said that you understand why patients' tubes fall out in the first 24 hours? Now, when you said that, were you thinking about all patients or patients with a bit of confusion or disorientation, or was it everybody?
Probably the patients who take a bit more reasoning as to why they need an NG. A lot of patients need. There's very few I don't know if it's the same for you, Josh, but there's very few conversations I've had with a patient where I've said you need an NG, and they just go, "Yeah, sounds good, get it done." It's always a debate. It's always the pros. It's always the cons. And it's usually the ones who are much more hesitant and have taken that much bigger conversation who have come back to the next morning, and it's fallen out in my sleep. And as we know as healthcare professionals, tubes don't just fall out; they need some form of force to come out. So if patients were feeling as miserable as I was for that first period, I can understand why, if they get a chance, that tube might start to come out.
Yeah. And I guess they've got other things wrong with them to feel miserable about in the first place. So
yeah, definitely.
We don't tend to put NGTs down people who are fairly healthy, do we?
No.
So one of the things you also mentioned in the article was that it was reassuring for you to have the experience that things improve after the first 24 to 48 hours, because that's often the kind of advice we give to patients. So having had the experience, is there anything you think should be done or said to patients to prepare them for the initial insertion and the first 24 hours?
From my point of view personally, I think it'd be a lot more beneficial for a patient if the person who's talking them through the NG tube was then the person who was doing it. So for us at the moment, we can't place NGs. So we will discuss everything with that patient, explain the pros, explain the cons, then go away to find a nurse or someone else to come place it. They might still be busy. And then it could be however many hours later, that patient's anxiety is built up, and then they've either refused the NG or they've got themselves so worked up about it that it's just simply not gone ahead. I think from my experience now, I can talk them through a lot more of the experiences I didn't expect, which I think has been helpful. Because even there's been some patients who've seen my videos on the UH&M group, and again they've said, "Oh, I saw you had that NG," and I think they're a lot easier come round to the idea of, all right, this is actually a solution. It's not here to hinder me.
Yeah. Okay. So I asked Josh about his experience of getting aspirate, because obviously you had the tube in for a few days. How and in the article you talk about some of the difficulties of feeding, but how did you find being able to having to check your own aspirate before you could feed?
Checking the aspirate was a nuisance. The best way I've described being nil by mouth and NG fed to patients now is that it's almost like filling up your car. You get no enjoyment from it, but it's a task you've got to do. In terms of getting the aspirate, because what I was trying to do for the first couple of days anyway, I was trying to just do my normal job, sticking to my gym routine, sticking my training routine, and then just have all my fluids and everything down the NG. But with having previous medical issues with kidney stones, I just couldn't run that risk of becoming dehydrated through the day. So that was the real drawback for me. It was I was getting worried about my hydration status, because I couldn't justify coming away from a ward round or seeing a patient to check my aspirate and administer water. It was just too time consuming.
But from being able to do it yourself, how did that go? How easy did you find it?
It's the preparation really. So say withdrawing the aspirate, unlike Josh, I didn't have any issues. I always seem to readily have aspirate. But then you've got to factor in, say, having your pH stripped. You've got to factor in just the general mess really of connecting a tube, disconnecting a tube, any spillage from the tube, having your napkins or serviettes ready to clear it up after. It's a time-consuming process. It's not a quick job. And say that's the thing I found straight away. If you're not organised, you spend more time chasing around trying to sort yourself rather than actually just getting it done.
If you were preparing a patient for discharge, even just in relation to getting aspirate, would that be the message? Almost a checklist. Get everything sorted.
Yeah, definitely. Get your space ready. I probably would say just having a clean space ready and having something probably that you can put all your stuff on that you can dispose of straight away. Because I did a lot of my feeds at our dining table, and even to this day, it still feels sticky. No matter how many times I clean this table, it still feels sticky.
Going to that, we talked about the aspirate, but how did it go actually, connecting up the syringe, because you bolus fed, getting getting the supplement in there? How did that all go?
Again, hard work. I mean, I'm fairly fit. I'm quite active, so I would have thought getting a. So I use quite a viscous supplement, and I still thought it would be easy, but it was a lot of work really. And even when I swapped onto higher volume 2 cal version, even then I just started diluting it with water to get it done quicker. Was my goal. Yeah.
Yeah. So
when you're trying to get the feed actually in with a syringe, you just get so much resistance.
Yeah.
Which you don't really expect initially, do you?
Yeah. I reckon if the syringes had a logo on it, I probably would still have a logo imprinted in my hand.
Yeah.
So, well, not an easy task.
No. And I suppose have you had to discharge any patients that are going to bolus feed themselves since you did it?
I always when discussing discharge of the patient, I always give them the option of what they want to do. So
Okay.
it's talking them through both options, and more often than not, they'll tend to give both pump feeding and bolus feeding a go in the hospital really, so they can decide what they want to do. I think in terms of my lifestyle, if I'd had a pump, I reckon I would have managed the NG much easier, because I could have walked around all day with just a backpack on and being fed continuously, get me fluids continuously, and that would have been much easier. But for some people who wouldn't have that option, or just prefer bolus feeding, it's really unique to the individual. There's definitely no one size fits all when it comes to home enteral feeding, as you probably know well.
Yeah, I think with NG tubes, I think bolus feeding is definitely a bit more of a time-consuming affair than if it was a rig or peg, just because of the size of the tube.
Yeah.
And you have to, as Phill said, you have to consider patients' lifestyles. If it's going to fit in with them and they're happy to be sat there for the half hour, 40 minutes trying to get this bottle of feed through a tube, then that's fine. But I think generally my patients prefer to have a pump feed if they're going to have an NG, just because it's so much easier.
Yeah. So I guess you had the advantage as a dietitian that you could adjust your regime as you went through based on your experiences and your monitoring. So what sort of adjustments did you make during the week?
My adjustments have pretty much always ended up just being an increase in my feed and altering my actual feed pattern. So like I said previously, on the first day I was just miserable. My motivation to do any form of feeding was so low. I can't remember the exact number, but I think I only managed 3 or 4 ensures, so that was about 1200 calorie, which for a chap of my size, definitely underfed, but just zero motivation. So as the week progressed, I was gradually increasing up the number of ensures, but then, as we were saying before, again, it ties into routine as well. So for me, I'm not a person who has breakfast, or I really struggle to eat early in the morning or take any form of nutrition in the morning, because I just feel sick for the rest of the day. So then I kept in the pattern of them. I had a lunchtime feed. Then when I got in from work, I would do a feed straight away first thing when I got home, and then I'd do a supper feed about an hour or 2 before bed, just because that was the way I found that was the quickest I could get in all my nutrition, or what I'd predicted to be my nutrition, without having an absolutely massive volume in 2 feeds.
Yeah. Okay. And one of the things that I thought about when I read the article was, you were able to do what you did. You could choose your routine, you could adjust it, you could adjust your intake and how you took it. In effect, constantly monitoring your response to the regime. That's really difficult and really different, I guess, from what happens with a patient in the community. How in an ideal world do you think things could be put in place to bridge the gap between what you could do and what is the reality for most patients?
Ooh, that's a good question. For me,
Thank you.
I think there's such a huge emphasis on nutritional requirements, and I think sometimes that can be quite misleading, especially for student dietitians. For me, the key to dietetics is monitoring. The nutritional requirements at the end of the day are always a ballpark. They're just to give us a rough starting point. Then it's monitoring anthropometry, it's monitoring weight to see if our feed is actually making a difference or making the difference we actually want it to make. What are your thoughts on that?
I guess in an ideal world, you'd be able to contact these patients on a daily basis initially after they start their feed at home. So they've got that close contact, they can keep in the loop with how things have been going, and you can make changes sort of really quickly and resolve any problems smoothly at that point. I think COVID, in a sense, has sort of helped that situation, because as we're doing now, there's a lot more sort of attend anywhere, or like sort of Microsoft Teams sort of style video conferencing, where it's easier to get in touch with people and they're not having to come to hospital. So that does make things easier in a sense. If there are problems, and especially with the video communication, you can, if there's an issue with the tube itself, the patient's there and you can have a quick look. I guess it all comes down to funding as well. At the end of the day, you need to have the time to be able to do these things. And in an ideal world, you would be able to, but that isn't always the case. And it is monitoring as closely as you can, having that sort of trust with your patient that if they have any problems, they call you and you get back to them as soon as possible to make sure that things are corrected or adjusted to make things easier for them. I think that's really important.
I think a massive part of that as well is patient education. I think, again, this is all down based on the individual. Some patients want to take responsibility, whereas some, because it's attributed to their illness, they want to have as little to do with it as possible. So realizing that they can help control it and monitor it better themselves is helping them take on some more responsibility than thinking, oh, this is slightly different, I need to contact such and such. Obviously, we're still always going to be there at the end of the day, but it's just making sure that patients can take some responsibility for themselves as well, if they're able to.
Building their confidence with that too. Yeah.
So I'm actually involved in some projects as well that look at PAM scoring with, assessing a patient as how engaged they are with their condition. As dietetics used tools like that before? Because it's what in effect you were just talking about. Decide how you decide what level of engagement the patient can have with their nutrition. Is that something that's happening?
I've done it more when patients are being referred for weight reduction than I have for nutrition support. So with patients, more often than not in the hospital setting, I will find that patients are referred for weight management without being told they're being referred for weight management. So have that chat with them, explain the referral, and say, essentially go through the basics of weight management. And that it's not easy. You actually need to put in the work. How motivated are you to do this? And I will usually let them say, on a scale of 0 to 10, what are your thoughts? If they're not interested, I'll leave it there and just say, come back when you're motivated. Usually give them a leaflet, give them a contact details. But I've never done it with nutrition support. I don't know about you.
But as you mentioned, there's sort of the motivational interviewing techniques and things that you learn you're learning through uni, and then you develop as you're actually in the job. I think they're the best ways to help you identify whether a patient is going to sort of manage the tube independently and what their barriers are to sort of getting more hands-on. They may leave it to the partners or the family members, and it's trying to pick at what is the reason behind that. Is there a way that we can overcome that barrier? Is there anything that we can do personally to try and help them build their confidence up with that tube? Everyone's different, but I think that's probably the best way that we try and pick at things and establish what may be getting in the way, really.
No, thanks for that. I appreciate I didn't forewarn you on that one. It's just it's one of my pet subjects at the moment. So having taken this challenge, and both of you took it, has that inspired anyone else in the trust to maybe find something similar and have a go?
I think there've been a few people doing different things. One of our diabetes dietitians used one of the self-monitoring pumps
All right.
So it's, scan it with the scanner to monitor your blood glucose levels that way. So yes, I think she really enjoyed that, didn't she?
Yes.
There've been people in our team who have done sort of liver shrink diets, who work in the bariatric team. So that's a really good insight. It's a really restrictive diet. So it's things like that we do try and get involved with when we can. So again, it's just about that patient experience, isn't it? And how putting ourselves in their shoes. So yeah, we do try.
Yeah, I was surprised when we did this again. I got a lot of comments from colleagues being like, "Oh, you're so brave. I'd never do that." And the majority of people saying this were nurses or doctors, so the people who are going to be putting these NG tubes in.
Yeah.
And I say for me, it was never a matter of bravery. It was just sheer interest. And speaking with some of the physios, they were saying about what could they do from a physio point of view. I don't know if anything's come from that. But they said I know they were interested to feed back to the manager and see what they could actually do that would be suitable.
No, it's good that it has sort of pushed people to think about what else they could do. So I guess my last question is, this got a lot of attention. It was obviously really useful for you and probably for the wider team. So how are you going to top it next year?
TPN.
TPN. Like you're going to get that through an ethics committee.
So imagine funding for that. I think this year's been almost written off, hasn't it, with COVID?
Yeah.
So I don't even think we thought about next year. Obviously, Malnutrition Awareness Week's coming up. I think we're doing again just some general education around the wards, but nothing further afield has come up yet. I don't know if I'm not volunteering for any pegs or rigs anytime soon.
I think we'll get away with that.
Hopefully, maybe someone else. I know a few in the department have said they want to give it a go. So I don't know if it might become a yearly volunteer thing. But I know there's definitely been some interest.
Yeah, well, maybe just having an NG down becomes a rite of passage. When you're on a team, you've got to have one.
I was going to say, I think that's the interesting point, because obviously when nurses and doctors place them on each other, they only have it in for an hour or half an hour or so. So maybe that's where this really almost negative mindset of NGs has come in that it's such an unpleasant experience because they haven't had it for long enough to get past that unpleasant phase, maybe.
Yeah, I think you're right. I mean, I have to say, when I was clinically nursing, I didn't have one down, even though I put a number in. I've had them since in different roles, but I didn't have one in then, and it did make me think when I finally got one down about how a patient will feel, even just on the insertion, tube coming towards your face. So I think it's been really good talking to you about your experiences. Thanks for your time, and
thank you very much.
Really looking forward to hearing what happens next year and what the next event for the dietetics team at UHNM is.
Yeah, we'll have to think of something now while the pressure's on.
Yeah, watch this space. We'll find something.
Cheers now. Okay,
thank you very much.
Thank you.
We'd like to make really clear is that unless explicitly stated, the views expressed in the NG podcast are those of the individuals and not those of NG Pod Global or of the organisations for whom the participants work. We hope you enjoy the NG podcast, and if you do, please subscribe or like or both on whichever platform you're viewing or listening to it on.